20 to 30% of patients will not access second-line options at all.
I hope in the future there'll be some guidance for us about those patients with low volume brain metastasis that maybe a maintenance strategy is appropriate.
So we've talked about, we've all obviously got patients already on DB09 regimens in the clinic today. What happens when and if, hopefully a long time from now, but what happens when these patients progress? Where do we go?
Yeah, it's the age-old question of sequencing and how complex that can be. But I think at this point, for me, if someone's progressed on the DB09 protocol, then I'm going to lean on the HER2 climb protocol, the triplet at that point. I think we shouldn't forget Kadcyla is a very active agent in HER2 positive amplified disease as well, and obviously the menu of chemotherapy options that follows. Obviously, if a clinical trial is available to me, I will always prefer that given that there are so many other standard options available. I have zanidatamab available in my center, and so that's something that I'm going to lean on.
Yeah, a really important area for clinical trials, obviously, going forward.
I agree with you. I tend to favor a strategy of, ADC followed by a TKI, followed by an ADC, followed by a TKI. For whatever reason, that seems to make sense to me, just alternating the mechanism of action. Although I think we're going to have to look, the standard of care is evolving so rapidly. We're not going to have large phase 3 trials to answer these questions about sequencing. We're going to have to rely on smaller studies, real world data. And I think that's something we all need to get comfortable with as oncologists. I hear all the time when I'm talking to people who've sent second opinions and they say, well, there's no phase 3 trial looking at this after that. And I've said, and there's never going to be. And so we're in this era where we really have to be looking at all the tools that we have and making the best use of those for the patients. And we're going to have to look at the best data that we have. And it might not always be a phase 3 randomized placebo-controlled trial looking at sequencing. It's just not feasible.
Now, what do you say to the person who thinks about sort of holding back DB09 for the second line? Sometimes I hear that strategy. What would your thoughts be on that?
I think you talked about 20 to 30% of patients will not access second line options at all. I think that's very sobering. And I think that's where one of my strategies would be, lean on the best tools up front.
Absolutely. And then just that fear that, that first place of progression might be their CNS. And that's not something that's easy to sort of regain or get control of once we've lost it. And even the treatments that we employ to sort of obtain control of CNS disease, no patient is ever the same after they have brain radiation. I mean, they will tell you, their families will tell you, they are not the same. And so even though we might be able to sort of, do some SRS or do something to sort of, placate that disease for a period of time, I don't think we can fully understand the magnitude that has on quality of life for patients. We also have to think about the issue of radiation necrosis surrounding the ADCs and timing of radiation therapy. That's becoming an area that we're becoming increasingly aware of. And we want to make sure. I have one patient right now that is completely without evidence of disease in the CNS or otherwise, and all of her symptoms are being completely driven by the degree of radiation necrosis that she has, which is extremely difficult to treat.
So let's think about, you want to say something to a physician, at home in the community who sort of sees everything as they're starting to incorporate DB09. What is one thing you would say to them?
Magnitude of gain in PFS, the complete response rates achieved with this regimen, the prevention of CNS metastases cannot be underscored and are hard to unsee. And I think that is the reason why DB09 will now be the standard of care for most patients.